Hi, this is Jamal Fatma. I'm an internal medicine resident at University of Pittsburgh Medical Center McKeesport. First of all, I would like to express my sincerest gratitude to Cardiovascular Innovation selection team for providing us an opportunity to share our interesting case with the rest of the world through this platform. So without further ado, let's get into our case. Today I am presenting an interesting case of Takotsubo cardiomyopathy with LVOT obstruction that's a very rare cause of peri-PCI hypertension. I'll start with the case presentation. So here we have a 57 years old female presenting with constant mid-sternal chest pain of constricting nature and 12 hours duration. She denies any radiation, exacerbating, or relieving factors. Her past medical history lacks cardiac disease. Her family history is significant for ischemic heart disease. On presentation, our patient was conscious and her vitals were notable for a heart rate of 145 beats per minute and blood pressure was normal. Rest of her vitals were unremarkable. Her physical exam was benign. Moving on to the investigations, the initial electrocardiogram showed ST elevation in chest leads V3 to V6. Her troponin level was also found elevated to 14.81 nanogram per milliliters. So her symptoms were attributed to ST elevation myocardial infarction and the patient was taken to catheterization lab for urgent PCI. The PCI revealed that she had left anterior descending and right coronary artery mildly diseased. However, the left circumflex artery had 20% mid-stenosis with a thrombus. So a thrombectomy was performed and a drug-eluting stent was deployed to left circumflex artery to achieve normal flow. So now getting into the complication part of our case. 15 minutes after the deployment of stent, the blood pressure of our patient dropped to 75 by 51 with a mean of 58 millimeters of mercury. This peri-PCI hypertension was resistant to fluid resuscitation as well as inotropic support. Given ongoing hypertension and the revelation of acute heart failure with right heart catheterization, an emergent echocardiogram was obtained that showed severely reduced left ventricular systolic function with an ejection fraction of 10 to 15%, along with regional hypokinesis of left ventricular apex with hyperdynamic basal systolic function consistent with Takotsubo cardiomyopathy. Other important findings included left ventricular outflow tract obstruction and a large ventricular apical thrombus. Upon this finding, inotropes were gradually weaned off and our patient was given metoprolol and phenylephrine to increase left ventricular diastolic volume and afterload in an attempt to mitigate the dynamic alveolar obstruction. This resulted in improvement in blood pressure and our patient was then transferred out of the catheterization lab to cardiac critical unit. Within the next few days, phenylephrine was also weaned off. Ultimately, she was discharged on warfarin for the left ventricular thrombus. An echocardiogram was repeated in 6 weeks that showed resolution of Takotsubo cardiomyopathy and normal size and function of left ventricle with an EF of 50 to 55%. So this brings us to our discussion. So as we know, the Takotsubo cardiomyopathy is a transient left ventricular dysfunction typically featuring apical ballooning with angiographically normal coronary arteries. It can masquerade as ST elevation myocardial infarction due to similar presentation. Approximately 10% of the patients with Takotsubo cardiomyopathy can develop cardiogenic shock, and that can happen during the PCI as well. Cardiogenic shock that is without alveolar obstruction is usually treated with crystalloid infusions, inotropes, vasopressors, and even mechanical circulatory support such as intra-aortic balloon pumps. However, The cardiogenic shock that is associated with alveolar obstruction in Takotsubo cardiomyopathy is usually dynamic and improves with increased left ventricular end diastolic volume that can be accomplished by adequate volume resuscitation or by prolonging the left ventricular diastolic filling time by giving beta blockers or by increasing afterload with alpha adrenergic agents such as phenylephrine. In cases that involve alveolar obstruction, afterload reduction is usually contraindicated. And lastly, the LV dysfunction can lead to apical hypokinesis that increases the risk of LV thrombus. That requires anticoagulation for 3 to 6 months. I'll conclude my presentation by going over the take home points. So, peri-PCI hypotension that is resistant to conventional treatment with fluids, inotropes, and vasopressors necessitates looking for alternative etiologies. As I mentioned before, Takotsubo cardiomyopathy can masquerade as ST elevation myocardial infarction, and when associated with dynamic alveolar obstruction, can cause peri-PCI hypertension. And our case also emphasizes the use of echocardiogram during PCI to look for the causes that can lead to peri-PCI hypertension. Thank you very much.